Okay, hi, I'm Ian Kovach. I'm an orthopedic surgeon here in Pratt, Kansas, specializing in hip and knee replacement. And if you're watching this video, you've been diagnosed with osteoarthritis of the knee and are potentially a candidate for a knee replacement. So with more advanced osteoarthritis of the knee, generically there's kind of three directions you can go, three choices to choose from. One is conservative treatment, and that's anti-inflammatories. Even the over-the-counters like Advil, Aleve, and Motrin are honestly about as effective as the prescription ones we use. Another aspect of conservative treatment consists of conditioning, generalized conditioning, and in some cases weight loss. There are a number of studies that show that conditioning and weight loss can positively impact the outcomes with knee replacement as well. Also in this category of not doing very much or conservative treatment would fall things like, changing jobs, physical therapy perhaps, basically changing your activity level and taking arthritis meds. Also perhaps different footwear. Option two is injections. There's a variety of types of injections, but the cortisone injections or cortisone derivative injections are really kind of the workhorse. They're the most likely to work, and they're covered by insurance, and they're generally kind of the ones that we do mostly. The cortisone injections are a strong anti-inflammatory. It's like prednisone is the oral version, which tends to kind of cool or quiet the inflammatory process in the knee. It doesn't really fix or change anything in the long run. Typically, steroid injections help a few months for the first few times, although there are really no guarantees. There are some patients where the steroid shots really just don't help at all, and some where they work pretty well for quite a while. Besides the steroids, there are other types of injections. One class is called viscosupplements. There's a number of different brands of viscosupplement available. Pretty much all of the commercial insurance carriers, as well as Medicare in most places, have stopped covering the viscosupplements because they're pretty unpredictable. There definitely are some patients who benefit quite a bit from them, but I think they're probably more the exception than the rule, at least in my experience. So generally we reserve viscosupplements for patients who really don't want to move on thinking about surgery, have failed steroids, and have milder arthritis. There are also a couple of other types of shots that fall under the biologics category. One is called platelet-rich plasma. That's where we take blood, centrifuge it, and then inject a fraction of the centrifuged blood back into the knee. It's kind of a so-so treatment also as well, and in my experience anyway. I think it does help people. Most people it helps some for a while. I don't personally think it's a lot different than taking a good anti-inflammatory for most people. But there's some variability in experience. It's also not covered by insurance because it's a newer, still sort of experimental technique. Reasonable to try, but again, more in milder cases generally. It, like the steroids, doesn't do anything to fix or restore the cartilage or change anything really long term. The other category under the biologics are stem cell products. And stem cell products, there's really no evidence at this time to justify using stem cell products for osteoarthritis or global wear in the knee, at least that I'm aware of. There probably will be a role for stem cells in the future, more to do with cartilage injuries. For example, if you have a pretty healthy knee, but there's a divot knocked out of it from an injury, the possibility of using stem cells with cartilage cells to regrow patches of cartilage, that, at least at the meetings I've been to, seems like a reasonable possibility in the future. But the use of stem cells for global osteoarthritis or just kind of wear and tear of an old knee, really there's no good evidence to support that I'm aware of. Also super expensive and not covered by insurance. And that brings us to the third option, which is knee replacement. Knee replacement's a pretty good operation. The vast majority of people do really well, but getting over it takes some time and some effort. In my mind, there's kind of 5 important things I think you need to understand if you're thinking about knee replacement. The first one is something that everybody pretty much knows, but it's good just to hear, and that is it really does not matter when you do it as to how you're going to do. In other words, it's not like a heart operation or cancer, something where the decision to wait or delay surgery might actually be a mistake. With knee replacement, it's really kind of the deal where when you're sick of it and you want to do it, do it. It won't be any harder to do. You won't have any worse outcome if you decide, maybe I'll try shots and get it fixed next year. So in other words, it's kind of a low pressure thing as far as making the decision. The other important things to understand about knee replacement, if you're considering one, what's the recovery process like? What are they like once they're broken in? what are the risks, and how long do they last. I always like to start with how long they last because that's kind of quick and easy. Over 95% of knee replacements last longer than 15 years. And that's based on really large data sets. Looking at implants, they're very similar to the ones we use now. And that doesn't mean that they all quit at 15 years in a day. That means 15 years out, over 95% are still functioning great. So realistically, I tell people if you're over 60, it's pretty much gonna last you a lifetime. It'd be awfully unusual to see one fail earlier. Reasonable chance it'll last you a lifetime if you're younger too. If you do wear one out, it's not the end of the world. You can redo them. We redo artificial knees, all the time for different reasons. So it's not like you can only ever have one done. Now, on to the other questions. What's the recovery like? Surgery really only takes about 1 hour with knee replacement. Most of the patients that we have nowadays are going home after one night, sometimes two. Most people are on a walker after knee replacement surgery for about a week. Physical therapy, typically for a month or two. It's really important not to expect to do great right out of the gates. You really have to be kind of patient at the beginning. First couple of weeks after a knee replacement's a lot of work. You're going to wonder if it was the right decision. Usually about 4 or 5 weeks out, things kind of start to turn. When we see people back for the 6-week visit, almost all of them are doing well enough that they say that they would go ahead and have surgery even if they didn't get better than where they were then. Not everybody, but most people. So the bottom line there, you just have to be kind of patient at the beginning. It does take effort on your part with physical therapy. But by 6 weeks, most people have turned the corner and they're feeling pretty good. To get as good as you're ever going to get after knee replacement can take a long time, even up to a year. But the vast majority of people are doing pretty well within a few months. I'm glad they did it. Excuse me, as far as the outcomes, once all the dust settles, sort of what are they like and how many people like them? In my experience, I think patient satisfaction with knee replacements is probably somewhere in the mid-90s. Probably 95 out of 100 people who have a knee replacement are happy about it, which is pretty good, for an operation like that. It's pretty good statistics, but it does mean 1 out of 20 people isn't fully satisfied with their knee replacement. And I think you have to go into that kind of eyes open that, not everybody does great with knee replacement, although almost everybody does. Of the 1 in 20 who aren't fully satisfied with their knee, I'd say about half of them are because they never really got the motion back they wanted, and the other half is because of persistent pain. Good artificial knees really have no restrictions when it comes to low impact activities. So walking for exercise, very realistic. Hiking in the woods, climbing a ladder, playing golf, all very realistic. Not so realistic would be repetitive hard impact loading, like running for exercise. Could you run to get out of the way of something? Sure. Do you want to take up running as a hobby? Probably not. Also hard twist pivots, the knee won't feel like the knee you had when you were 20. But pretty solid, pretty versatile, and very few limitations. Kneeling, not everybody, most people with knee replacements don't like to kneel. It's not going to damage an artificial knee to kneel on it, but the feeling of pressure along the incision is something that most people with artificial knees feel is uncomfortable. If you have a hobby where you have to kneel, say you're a gardener or something like that, it sure is possible. Just get good knee pads and you'll be fine. But again, don't count on being, don't count on being easily able to kneel without discomfort. Artificial knees have a couple other quirks. Your non-artificial knee has a little bit of side-to-side wobble. We try to copy that in the artificial knees because we're trying to copy what was in there before. But since the artificial knees are made out of metal and plastic, you'll get pops and clicks. They're a little bit different than you're used to with artificial knees. It doesn't hurt, but it has a sort of mechanical sense or sound to it at times. Also, any incision down the front of the knee leaves an area off to the side and below where the skin is kind of tingly or sleepy. And that never really goes away completely, but your awareness of it tends to fade over time. So most people don't notice it after a while. That's it for expectations, I think. As far as risks go, they're real, but they're also really rare, and we get you through most of them without too much of a headache. It is important to understand when we're talking about risks. In addition to the ones I'm going to talk about, there are other unforeseeable risks or other risks that may not be mentioned, which are really rare. The ones we worry about most, for example, infection. It's about a 1 in 200 risk with knee replacement. If you do end up with an infection, we're pretty good at getting rid of it. Our success in curing infections in prosthetic joints is over 90%, but If you have an infection in a prosthetic knee, you're going to have at least one more major operation, and you're going to have at least 6 weeks of intravenous antibiotics. And that's if everything goes to plan. So it's a headache to treat. We're pretty good at curing it, but it's really only about a 1 in 200 risk to begin with. Now, that being said, that 1 in 200 number that 1 in 200 number does depend on other risk factors. For example, diabetes, or folks with higher BMI are at higher risk. Other risks, blood clots. We do everything we know how to minimize the risk of blood clots, but even with every precaution we know how to take, there still is a 1 in about 2,000 chance of dying from a blood clot following knee replacement. I've been at Pratt, gosh, for 21, 22 years now. We've done about 6,500 hip and knee replacements on my service in that time. And of that group, we've only had 2 fatalities from blood clots. So it is a risk, it is real, but it's also very rare, and we do everything we know how to prevent it. Metal allergy is something worth discussing. It's a little controversial how prevalent it is and how significant it is. But we do prefer, if you're someone who has had skin reactions to earrings, for example, or belt buckles, or has any reason to think that they have a reaction to metal, it's very easy to use hypoallergenic components, which just sidestep that issue completely. So if you do have issues with metal sensitivity, make sure to let us know. Excuse me. Other risks, damage to nerves or vessels. We know where they are. We don't cut them. I suppose anything could happen, 1 in a few thousand. But realistically, the risk is more to do with stretch injury of the nerves. Statistically, it's probably a 1 in 300 risk, 1 in 200 risk. I think in my experience, it's probably a little less than that. But it can happen, particularly with certain deformity patterns in the knee. Usually the nerve comes back and works fine. Again, pretty rare and usually self-limited. Other than that, anesthetic risk, anesthesia is pretty safe. Vast majority of people do really well. The focus these days is more on what we call regional anesthesia. So they give you injections to knock out the nerves that go to the knee, so they don't have to give you nearly as much medicine to put you to sleep or to make it so you don't feel it. Generally, I'm just really pleased with how anesthesia is working these days. We're usually able to get people up walking the same day as surgery. And while it certainly isn't pain-free, when the blocks work effectively, it really is a dramatic improvement from how it used to be some years ago. That's pretty much the main stuff as far as risks go. Now, you'll see one of us here in a few minutes, and if you have any questions about anything that we talked about here on the video, please let us know.